Hello and welcome. My name is Kat Davis Ahmed, and I am Vice President for Policy and Outreach at the FH Foundation. Welcome to our webinar, The Role of Lipoprotein Apheresis in Familial Hypercholesterolemia, Elevated Lipoprotein A, and Cardiovascular Disease. We are joined for this webinar by Dr. Patrick Moriarty of the University of Kansas Medical Center and FH Foundation Advocate for Awareness, John Tvrdy. Next slide. I would like to remind everybody that this is a webinar for your information. Please, if you have any questions about your personal medical care, consult your doctor and your medical team for your specific recommendations for your treatment, but we hope you find this webinar informative. Please take a minute to introduce yourself in the chat, say hello. Be sure to choose all panelists and attendees so that everybody can see what you post, and just say hello, who you are and where you're from. Love to hear from you. And we will take some questions at the end after the presentation. And so if you have questions, please enter your questions in the Q&A. You'll find the Q&A box at the bottom of your screen. And you can enter your questions anytime throughout the program. We'd like to thank the sponsors of all of our Community in Action programs, our FH Community in Action program, sponsors Amgen, Esperion, and Konica, the Lipoprotein A Community in Action program, Amgen, Novartis, Konica, and Silence, and the HoFH, Homozygous FH Community Programming from Regeneron, Invitae, and Amrit. And particularly our FH family partners, all of you who support the FH Foundation and our work. And we'd particularly like to thank Konica for this webinar about lipoprotein apheresis. The reason we wanted to have this webinar is that lipoprotein apheresis is an important treatment option, but is often not well understood. And these are pictures of a couple of people, important people in our community who do lipoprotein apheresis. It's not especially common in the United States, and it can be hard to find a lipoprotein apheresis center. And we know that this option is often not even mentioned to patients. And certainly it's not for everybody, but it is an important option that we want people to understand better. So our goal for this webinar is to hear from Dr. Moriarty, a leader in the field of apheresis, and also from Don Tvrdy about the experience of doing apheresis, and so that people who might want to consider this as a treatment option can understand it better, and maybe even take this information to their healthcare provider if it's something that they'd like to discuss further. And really the goal is to make, when it comes to all treatment options for FH and elevated LPLA, we want you to be well informed and know all of your options so that you can make an informed decision. So with that, I would like to introduce Dr. Patrick Moriarty. We're just thrilled to have you. Thank you so much for presenting. Dr. Moriarty is Professor of Medicine at the University of Kansas Medical Center in Kansas City, Kansas, and the Director of Clinical Pharmacology and the Atherosclerosis and Lipid Apheresis Center there. He's a fellow of the American College of Physicians, the American College of Cardiology, the European Society of Cardiology, and the National Lipid Association, and was the president of the International Society for Apheresis in 2014-2015. And he's the associate editor of the Journal for Clinical Apheresis and Clinical Lipidology. So really, we couldn't have a better presenter to educate us about the role of this therapy for the conditions that we'll cover today. He's published over 100 peer-reviewed articles and chapters, and his research activities include atherosclerosis, familial hypercholesterolemia, lipoprotein A, apheresis, vascular inflammation, dementia, and this is new to me, hemorrhoids. He's participated in numerous clinical trials related to dyslipidemia, LPLA, obesity, hypertension, dementia, and diabetes. Very importantly, and we're very grateful, Dr. Moriarty is a member of the FH Foundation Scientific Advisory Board and a real leader in our Cascade FH Registry network with, I believe, the highest enrolling numbers in the registry. We're grateful to him and his entire team at the University of Kansas Medical Center. where the apheresis center is the largest in North America for the treatment of familial hypercholesterolemia and LPLA. So thank you so much, Dr. Moriarty. I'm really looking forward to this presentation and to our discussion afterwards. And with that, I will leave it to you.
Thank you, Catherine, FH Foundation, for inviting me, and also Don Tvrdy to this session. And I'm happy to present this discussion. I'm not going to talk about newer medical management. I saw that in my title. I apologize for that. But let's go ahead and start talking about this topic. Next. Here are my disclosures of my associations with industry and research and so forth. Next. Let's start with FH, which occurs in 1 to 200, 300 people. And there's 4 major mechanisms of FH occurring, be it with the receptors or the ApoB lipoproteins or PCSK9 and so forth. Next slide. What we do know is that because you have disease, dyslipidemia at birth with FH, your risk of disease associated with LDL levels is much higher than someone who develops dyslipidemia based on lifestyle. As you can see in this slide, having FH and having the same LDL level as someone without FH, your risk of cardiovascular events is greatly augmented based on residence time of the atherogenic particles in your body. Next slide. And more recently, it's been found that actually cardiovascular disease, which was going down quite dramatically over the last 30 years from 1980s, is now started to go up again. And the reasons could be related to that we're actually living longer. And if we live long enough, we're either going to die from some form of cancer, most likely, or more commonly, it's a cardiovascular event. Next slide. The good thing is the pharmacotherapy that's been developed over the last 40 years, starting with statins, has really done a dramatic effect on reducing the risk of cardiovascular disease by reducing the atherogenic ApoB lipoproteins, all the way up into the new angiopoietin 3 infinacumab for HoFH patients and familiar combined FH patients. Next slide. And these medications have shown, be it PCSK9 inhibitors, be it ileal bypass, be it bile sequestrants, statins, diet, they all affect lowering LDL, which returns affects lowering cardiovascular risk. By lowering the substrate that causes atherosclerosis, you're lowering your risk of cardiovascular disease. Next slide. And we know now from data, the earlier you start in treating dyslipidemia, particularly in this case, FH, the sooner you get benefit in lowering cardiovascular risk. Now, this is not practiced presently in non-FH patients as much as it is in FH, which it should be in FH. But I think as time goes on, we'll realize you have this toxin in your body, and the sooner you treat this toxin and get rid of it or lower its levels, the more benefit you're going to get long-term. Example of someone with hypertension without symptoms, you don't wait till they have symptoms, you treat the hypertension now. And I think this is what's happening with ApoB, and this will be developing as time goes on, I believe. Next slide. But when it comes to genetics, FH is not the only player in town. And LPLA, lipoprotein A, has become more and more recognized as a cardiovascular risk factor. It's been known since the 1960s, but now we're realizing due to clinical data and outcome data that it's becoming more prevalent in the sense of our knowledge because we're measuring it more. And it basically is an LDL moiety with the ApoB in this protein A, which structurally looks similar to plasminogen, which because it has an innate inactive protease domain, unlike the plasminogen, it doesn't break up clots in your blood, which plasminogen normally does, because your blood is constantly clotting or unclotting on a 24/7 period to keep your blood from bleeding to death or from clotting to death. So when you have a clot in an inappropriate place, plasminogen goes there to break it down. But with lipoprotein A, it will go to that clot, but not activate the fibrinolytic cascade of breaking it down. Next slide. So besides the procoagulant, prothrombotic association, as you see here, and the proatherogenic, LPLA contains a lot of inflammatory cells, and mediators particularly, in this case, oxidized phospholipids. And they're major players within the plaque of an artery that helps destabilize the plaque to make it susceptible to rupture, which can cause the acute event. Next slide. And it's been shown now that LPLA, this is a study looking at the LPLA genome and showing the risk of CAD as the LPLA levels increase. Normal, in this case, this is in mass milligrams per deciliter. Normal is less than 30 milligrams per deciliter. Next slide. This is a wonderful paper that was published almost 10 years ago now, looking at genetic SNPs to predict correlation to valvular calcific aortic stenosis. And the only one that jumped out, as you can see in the middle of the page, was LPLA as a major player in calcific aortic stenosis. Next slide. And stroke. Stroke has also been shown to be strongly associated with LPLA, but in a certain manner, and I'm going to show you what I mean by that. Next slide. This was a study called the BioSignal trial that was published this year, European Heart Journal, and they looked at 1,500 patients who had a stroke. And they followed them, a thrombotic stroke, and they followed them for 1 year to see who would have a stroke again. And about 10%, about 150 had a thrombotic event. And they found that the patients, as you can see here, the patients who had LPLAs above 100 nanomoles per liter or 40 milligrams per deciliter, and nanomoles per liter, the normal is less than 75. So it's not at a very high level. You could see the significant difference in events based on the LPLA level. Next slide. They further broke it down and found three other aspects of this. One, if you had a large arterial atherosclerotic event for a stroke, basal artery and so forth, instead of a small minimal artery, or if you had no history of AFib and you're young, meaning you are less than age 60 compared to the other three, as you see on the right-hand side, your relationship to LPLA and having a stroke was strongly correlated. And we find in my clinic, many patients with LPLA developing more strokes than cardiovascular events. Next slide. Now, this is an interesting information. Now, so in adults, the majority of thrombotic stroke is associated with atherosclerosis compared to only 2% in the pediatric population. So only 2% of young people who get strokes by thrombotic means are finding a source of a plaque like you see in adults. And in patients under 55 years of age, cryptogenic stroke, meaning strokes of unknown etiology, account for almost 40% of all these ischemic strokes. And we're now thinking that this might be related more to LPLA, which it hasn't been investigated yet. Recent data has shown that children with an elevated LPLA level above fourfold risk of an acute ischemic stroke, and that risk of ischemic recurrent stroke, as I showed you earlier in the BioSignal trial, it can be, normally it's about 5 to 15% repeat stroke. If you had an LPLA in the highest percentile, 90th percentile, you had a 10 times increased risk of developing another thrombotic stroke if it was associated with your LPLA level. Next slide. Why is this important? Well, unlike FH, which is 1 in 200, 1 in 300 in the population, LPLA elevation is found in 1 in 5 people. And in some areas like Africa and India, that correlation is even higher of having high LPLA. Other places like China and Japan, it's less. The United States, since we're a mixed bag of population, it's variable depending on what part of the population we're talking about. Next slide. In Europe, with this knowledge, 3 years ago, the European guidelines, or 2 years ago, the European guidelines recommended that LPLA measurement should be considered at least once in each patient's lifetime. We don't have that yet, but I guarantee you it's coming soon, not too long, probably after the new LPLA reducing drugs that we're part of become to market if they were successful in the clinical trials we're participating. But it should come out sooner than that, but I don't think it will. Next slide. Why is this important? Well, first of all, LPLA levels don't change once you're born. Generally, they stay the same unless you go into menopause, and because estrogen can lower LPLA, In menopause, your LPLA for women might go up in menopause. And if you develop chronic kidney disease, because part of LPLA is degraded in the kidney, your LPLA level might go up also. But generally, low-fat diets, exercise have no effect. Niacin has been shown in the past to lower it by maybe 30%, but unfortunately, niacin has not shown any clinical benefit by doing that. And in fact, niacin, as you know, besides lowering LPLA, it also increases glucose levels and increases uric acid levels. So it might be the negative effects of niacin might inhibit the benefits of lowering LPLA. But whatever, it's not been shown. In fact, in Europe, they banned niacin therapy as a treatment because of the clinical trials showing no benefit. I did mention estrogen might help. This a study of the Women's Health Study, and aspirin might help in the same study that was done with women, showing a modest benefit of lowering LPLA and maybe lowering cardiovascular events. Next slide. In statins, if you know or don't know, has been shown not really to lower LPLA. They actually can raise it by 20%, and they can raise that oxidized phospholipids I mentioned here earlier. But that being said, statins are still good because they lower ApoB lipoproteins. So never refuse a statin to a patient, or never have a patient refuse a statin, because you still get benefit, and benefit outweighs the negativeness of the LPLA. It's just that the benefit is attenuated because of the high LPLA in the vascular system. Next slide. So what do we do? Well, let me go back a little bit. Let's say about 15 centuries, and talk about Hippocrates, who said, medicine is the art of addition and subtraction. The subtraction of all that is excessive and the addition of all that is missing. And he or she, who might be the best at doing this, will be the best healer. Next slide. And that's where apheresis comes in. And apheresis can be broken down generally into preparative apheresis, where you're taking out constituencies of the blood or the plasma for future use, like plasma exchange. You take plasma out of someone to keep for that person you're going to give it to. Then you have therapeutic apheresis, and they have non-selective, where plasma exchange is non-selective, and it's not selecting everything. It's giving someone new plasma that you'd remove from the patient. Semi-selective, and then the more selective type, and that's where lipid apheresis comes under. Next slide. And that's where dextrin sulfate apheresis comes under. It's all right, you can move ahead. So that's the one machine, as you can see in this picture, that's approved by the FDA to be used in the United States. There's another machine by the German company B. Braun, the HELP system, but they pulled out of the United States about 5 years ago for reasons too complicated to explain. Move ahead. Next slide. So this is how this works. Basically use antecubital veins, draw the blood, add heparin to the blood so it stays anticoagulated. And then you go through a plasma separator, separate the plasma. Next slide. The plasma where the ApoB lipoprotein is contained then goes through this liposorber column, which is actually dextrin sulfate. You see, ApoB lipoproteins are positive charge compared to isoelectric. And dextrin sulfate is a negative charge filter, a molecule in this filter, and it captures all the ApoB lipoproteins. And then once they do, the plasma is sent back to the blood to be brought back to the patient. But after about 500 cc's, this plasma gets full of cholesterol, and the filter gets so full of bad cholesterol, it gets kind of clogged. So what happens? Next slide. We switch over to another filter that's on the machine. And while we're using that filter, the previous filter that was full of bad cholesterol is cleansed. So after the 500 cc's of the new filter, we go back to the previous one. So basically, we can use unlimited amount of plasma volume as long as the plasma separator stays viable. Next slide. Let me give you some little logistics about it. So the blood flow is very low, 50 to 100 mLs a minute. You compare that to dialysis, which is like 500 a minute, can be very dynamic. That's why they need ports and fistulas, because of the hypodynamic flow. And the plasma flow rate is about 15 to 30 mLs. And the treated plasma is 2 to 5 liters, depending on body mass, hematocrit, and so forth. And treatment time is 2 to 4 hours. 4 is pretty excessive, but about 2 or 4 hours. Blood access, most of my patients are on vein to vein. If you have decent veins, this works very well. But because these patients have vascular disease, their venous access might be poor, so we might have to use a fistula, or we might use ports. Next slide. Adverse side effects, like any apheresis process, really not much. The most common is the venous access, as I mentioned earlier. So if you have poor venous access, over time we might have to put you on a fistula or a port because of that problem. But that's mainly the most common thing. And all these other ones are very minimal. And sometimes they are occur in the beginning of treatments. Once patient gets acclimated to the therapy, it's pretty safe and benign. Next slide. And these are the guidelines that the FDA has given us for use of apheresis in patients. The first two are basically primary prevention, be it HoFH, FHH, LDLs over 500 or 300. And all these patients are maxed on pharmacotherapy, of course. We don't start without treating them first on a statin, PCSK9 inhibitor, whatever, to try and get them to goal. This is after they're not at goal and they're still at these levels. And type group C is the classic LDL greater than 100 with cardiovascular disease, maxed out on pharmacotherapy. And the fourth and most recent one is the high LPLA. LPLA is greater than 60 milligrams per deciliter. But the FDA, when I went with the company to get this approval, they were fearful we're going to lower LDL too much if the LDL was already low, and they're afraid of the consequences, which, as you all will know, that's kind of ridiculous. But in Germany, they don't require that at all. So they require an LDL of 100, and that's kind of subjective when I work with my insurance companies of patients based on the severity of the disease. Next slide. Now, speaking of the Germans, they have the largest apheresis program in the world. They treat over 3,000 patients, where we treat only 300 in the United States, even though we're 6 times their size. And they have a 7-year registry called GLAIR, German Lipoprotein Apheresis Registry. So let's go to the next slide. And basically, it contains about a third, a little bit over a third, almost a half of all those patients I mentioned in Germany. And 40% are FH, and of them, majority of them are HeFH. There's one autosomal recessive that's being treated, but more than 50% of patients are being treated now in Germany based solely on LPLA in cardiovascular disease. Next slide. This gives you an idea of the 7 years, the gradual reduction of baseline LDL and the reduction of the post-LDL. So there's a modest reduction of chronic LDL levels. Next slide. And LPLA is actually more dynamic, believe it or not. You can see here the dynamic reduction of the LPLA levels compared to pre and post over time. But this, you got to realize they've added patients during this trial and so forth. So it's a little bit skewed, but it just shows you the benefits occurring. Next slide. Now, what about outcome? Well, this is looking at MACE. Now, MACE is a term used in medicine, particularly cardiologists, for major atherosclerotic cardiovascular events, meaning a heart attack, a stroke, a PAD, a AAA, any kind of vascular event related to atherosclerosis gets this term MACE. And so this looked at all the patients with a high LDL greater than 100 milligrams and normal LPLA, in this case, less than 60 milligrams. And you can see the red is the event rates of these patients before they start apheresis. So the control group is the patient's previous medical history. So you can see right after the bat, you get a dramatic reduction of events. And as time goes on, it stays fairly well stable, these patients having less than 10% event rate as time goes on. Next slide. This is looking at patients with LPLA. You see a more dramatic reduction right off the bat with event reduction over 80%. And that 10% and less is consistent again all through that on basically just high LPLA with a normal LDL. Next slide. And this is looking at all these patients that had both high LDL and high LPLA, again showing a dramatic acute reduction that was sustainable as time went on with continued therapy. Next slide. This is from our site. As Kate said, we have the largest center in North America. We treat, believe it or not, we treat more patients than all of Boston, New York, Chicago, LA, Dallas, and San Francisco combined. Makes no sense. We don't have that many patients that have FH that make that sense. It's just that we have a center that treats them, where you get referrals. And these patients should be all over those kind of studies I mentioned like they are here. So this is a study looking at patients with high LPLA, in this case, 138, these are milligrams per deciliter. I'm sorry, they're not in there, with an LDL baseline of 80. And we looked at their event rate before starting, in this case, 72 months, and we saw they had 36 MACE, myocardial infarction, cabbage, stents, forehead strokes. And then we looked at them, next slide, 4 years later on apheresis. And you could see the L and LPLA levels go down quite dramatically. And the MACE events go from 36 to 2, and all they were stent placements in 2 patients. And no other heart events were occurred over this 48-month period. Next slide. Now, Kate brought this up, but I'm going to kind of talk about this because people consider apheresis the same as plasma exchange, and it's not. Plasma exchange is exchanging someone else's plasma to your plasma. This is actually improving your plasma blood constituents, and I'll show you what I'm talking about. Next slide. So as I mentioned, the ApoB has a positive charge to it, and the dextrin sulfate has a negative charge, and it binds these. But HDL, next slide, HDL is negative charge, so there's a repulsion of HDL against the filter, so we shouldn't be lowering that much HDL, and we're not. We're lowering about 10 to 20% of HDL. So some HDL is being removed. Next slide. And why is that? Well, it appears HDL is a funny protein. We know it's a U-shaped curve related to benefit and harm, meaning a low HDL is associated with heart disease, but a very high HDL might also be associated with heart disease. And we think this is related to the plasma proteins that are bound to this. See these plasma proteins? The ones on the right increase your risk of heart disease if they're bound to HDL, and the ones on the left are more often considered safe. Next slide. So a few years ago, I did analysis with Jay Heineke's group out at the University of Washington, Seattle, doing HDL proteomics, where they measured the proteins of our patients, apheresis patients, pre and post apheresis. Next slide. And lo and behold, the top ones in the white all got better in the sense they were more of protein concentration of HDL after apheresis. And all those proteins, A1, A2, LCAT, PON3, are all good for HDL. Meanwhile, the ones in the bottom, ApoB, ApoE, ApoC3, LPLA, serum LPLA, they're all being reduced. And these are bad proteins bound to HDL. Now, plasma exchange does not do that. They're exchanging someone else's plasma to yours. They're not doing that to your HDL. Next slide. Inflammatory markers. This is a list of inflammatory markers that are reduced acutely and chronically with apheresis. The LPLA, the CRP is like 65% acutely, chronically it goes down by 50%. So vascular inflammation is greatly reduced. Next slide. Even interleukin-6, the major cytokine in the so-called cytokine storm associated with COVID-19 these last 2 years, is reduced by about 30% with lipid apheresis. This is Claudia Stefanuti from Rome's work, published in Atherosclerosis Supplements. Next slide. This is another study by Van Werkenen's group in Europe. They used PET imaging to look at the arterial wall inflammatory plaque before and after apheresis. As you can see, the plaque itself, besides vascular inflammation being reduced, the plaque inflammation was reduced following lipid apheresis. Again, something else that plasma exchange does not necessarily do. Next slide. And this is a more recent paper from Jack showing, as you can see here, if a high inflammatory vascular problem, the higher risk of cardiovascular events occur, like CRP, IL-6, and so forth. So if you have increased inflammation in your blood, you have increased risk of vascular disease. I put inflammation as like you have a fire, and inflammation is the kerosene to that fire. The fire is the ApoB lipoproteins. Inflammation is the kerosene. Next slide. But isn't it interesting that you only get atherosclerosis in only these arteries? No veins at all has atherosclerosis. No veins. Radial artery, you don't get atherosclerosis. Mammary artery, you don't get it. Use it for bypass. So why did these arteries, even though inflammation is distributed throughout all the arterial and venal system, why is it located only in these arteries? Next slide. And this is what Kate was asking about, hemorrheology. It's the study of blood rheology, which is the study of blood viscosity, which is the resistance of blood flow. Blood, unlike plasma and water, is a so-called non-Newtonian fluid. So stress is put upon it will change its resistance to flow. For example, blood is like ketchup. A glass of ketchup is like ketchup. You pour it over the sink, eventually at the Heinz commercial, it's like water, and blood's the same way. So when blood is stagnant or reverse, its resistance to flow goes up because its residence time is longer in that area, and it damages the wall. And that's what we call shear forces, particularly shear stress. When you have low shear stress or reverse shear stress, which is the tangential force against the wall of the artery, you cause more damage. Plasma and water, they don't change. They're the same no matter stagnant, reverse, forward. Next slide. Here's a nice diagram by Moriarty. He's a neurosurgeon in Boston. He published this 20 years ago in JAMA. So you look at the endothelial wall, they're like shingles on a roof. And this is normal blood flow, and everything's nice. You're getting nice side effects from this is very quiescent and stable. But once you get this oscillating flow, turbulent flow, stagnant flow, reverse flow, you activate all these pro-oxidants and cause damage in the endothelial wall to activate the whole atherosclerotic process. Next slide. And lo and behold, when you look at a normal vein, blood flow is not pulsating, it's always positive, it's never stagnating, it's slow, but it's always positive. Or normal artery is always positive. In arteries that blood flow is stagnant, reverse, that's where you find atherosclerosis, carotids, coronaries, abdominal femorals. In high shear areas where the plaque can get torn. Next slide. And guess what apheresis does to this? Apheresis lowers blood viscosity quite dramatically. By reducing all these proteins and changing the quality of the proteins, it's a euvolemic procedure. You're changing, I tell my patients, I'm changing your blood from ketchup to tomato juice. And think of pouring ketchup through a straw compared to tomato juice. The latter is much more efficient. Next slide. I want to give you a couple examples of this. This is from a colleague of mine, Klaus Melwerk from Germany, these are 9 FH patients. 8 of them had bypass, the other ones had a few stents. And this is looking at myocardial blood flow, coronary flow resistance, minimal coronary resistance, coronary flow reserve, after 18 hours after apheresis. And look at the dynamic improvement, 18 hours after apheresis by these patients. Dramatic improvement. Next slide. And here's the PET scan. You can see the dipridamole scan. You can see this, when it's blue color, that means low blood flow. When it's red like this, that means the flow has increased quite dramatically, showing improved hemodynamic flow in the cardiac muscle. Next slide. This is another interesting case that came to me by my neuro-ophthalmologist at KU years ago. So, and I didn't know about this, but anterior ischemic optic neuropathy is the most common cause of acute blindness. And it's a medical condition involving acute loss of vision due to insufficient blood flow. Now, there's an arthritic acute ischemic optic neuropathy. This is a result of inflammatory disease of the arteries. And then there's a non-arthritic, which is not it's not an inflammatory disease, but it's a small vessel occlusion based on flow dynamics. Next slide. So I was referred this young lady, 29-year-old, with CNS lupus for 3 months. She was on IV steroids, Cytoxan, prednisone. Then she developed a 3-day history of acute right eye blindness. The angiogram showed branch retinal artery occlusion, and it was called NION by the radiologist, and I'll show you shortly. And her lab showed that she was FH. So the neuro-ophthalmologist, Tom Whitaker at KU, called me and said, what do you think? I said, well, I think we better treat her with apheresis. I'll show you the angiogram first. Go ahead. Next slide. So you can see the angiogram here. You see how it's kind of tapered right here? That's not a thrombotic event. Because a thrombotic event, it's a denervation of blood flow and no blood flow. This is a gradual slowing of blood flow, and it was read out by the radiologist as increased blood viscosity or increased hemorrheology cap. Next slide. So we decided to treat the patient with apheresis. You can see the changes in the LDL, the fibrinogen, and the CRP, and look at the change in blood viscosity. First of all, she had a pretty high viscosity to start with compared to the ones I showed you earlier. And look at the change, pretty dynamic on this young girl. And we treated her 4 times over a period of time. Let me show you, next slide. And that's what we saw. Vision came back. She did great. And it cleared it up very dramatically for this young girl. So now she's on immunotherapy and doesn't need apheresis anymore. And she's on PCSK9 inhibitors too, so her LDLs are under control. Very, very well done. Next slide. PAD, peripheral arterial disease, is a very common disease as we age. You find in lower extremities, particularly in diabetics. Diabetics have a 10 times higher risk of this kind of problem. Next slide. And incredibly, the 5-year mortality from PAD is almost 50%. It's more than breast cancer, colon, rectal cancer. Next slide. Why do they have this? Well, if you have PAD, you most likely have some CAD or some cerebrovascular disease. So these patients with PAD will eventually die from some other cardiovascular event based on the relationship to the systemic disease based on what these patients are having, not just localized in the peripheral arteries. Next slide. So in Japan, they have a little diverse indications for using lipid apheresis. First, they use total cholesterol for FH over 250 with, resistant to drugs and with heart disease. And they recommend weekly or biweekly apheresis. In patients with peripheral arterial disease in the middle, they have to have a total cholesterol greater than 200 or an LDL greater than 140, and their drug resistance in their Fontaine grade greater than 2. And that's a grade of how severe the PAD is. And they only need 10 treatments over a 3-month period, and that's all they need. They also have been approved for focal segmental glomerulosclerosis, a form of kidney disease. And again, patients are drug resistant with nephrotic syndrome, and they recommend 12 treatments over a 3-month period. Next slide. This is one of their studies by Tushida and his group published in International Angiography back in 2006, looking at about 33 patients with intermittent claudication, PAD, and they want to look at some significant physiological measurements like ankle brachial index, maximal tolerated walking distance, how far you can walk, maximum recovery ability index, and plasmography, which is a way of measuring blood flow in the arteries of the lower extremities. Next slide. And look what they found. 60% improvement ABI, 70% improvement in walking distance, and 57% in the recovery ability index, and 50% increased blood flow. Again, related to, I think, a combination of the rheology, the inflammation, and also the reduction of the LPLA proteins. Next slide. Here's one nice case that they had out there that I thought was pretty impressive. This is a patient on lipid apheresis, 50-year-old woman on dialysis with this severe, as you can see, way to the left, ulcerative lesion. And she was put on 10 treatments, as you showed for PAD. This shows you after the 10th. This is 5 months after apheresis, showing dramatic improvement of the ulcer based on improved blood flow, which increases oxygenation in the healing process. Next slide. So, in summation, lipid apheresis removes ApoB containing lipoproteins by 60 to 75%, improves HDL functionality, we believe, lowers vascular inflammation, inflammatory markers such as CRP, fibrinogen, IL-6, galactin-3, reduces blood viscosity by 20 to 30%, improved for CAD, CVD, PAD, FSGS, and possible other vascular benefits not yet investigated to be seen in the near future. So I'll stop here and send you back to Kate, and I'll be happy to answer questions later on. Thank you.
Wow, Dr. Moriarty, that's incredible. It's a great presentation. I know I learned a tremendous amount, and it made me really understand apheresis and its role in FH, LPLA, and cardiovascular disease management a lot better. It's a lot more complicated and than I understood. So thank you so much. We would love to now hear from Dawn Tvrdy. Welcome, Dawn. Thanks for joining us. She's an FH Foundation volunteer advocate for awareness, and is being seen by Dr. Moriarty in Kansas, and Dawn is here to share her experiences. So I know that apheresis has been an important part of your treatment plan for some time now, and I wonder if you would share with us a little bit about your experience with FH, LPLA, and heart disease, and how you ended up doing apheresis as a treatment option.
Okay. Just a little bit about myself. I was born and raised a Midwesterner, and I married my college sweetheart, and we had 4 boys. And I also knew that early heart disease plagues both sides of my family, claiming the lives of many of my family before they were even turned 50. My dad had his first heart attack at 47 and lived to be 68. But I always dreaded that day, and I knew it would come when you get that phone call that your dad's heart disease took him. So, but going back, I really did find out I just had high cholesterol at 18. And I tried all kinds of medications, everything that came down. And I've always dieted and exercised, and nothing ever worked. So when I was 40, my nurse practitioner actually said, "Hey, there's a doctor down in Kansas City. You should go see him." His name's Dr. Moriarty. She even said his name. I mean, because that's one of those names you remember. And you know, he's doing this thing called apheresis to lower your cholesterol, and I think you should go. And I'm like, I have 4 boys I'm running with. I don't think I have time for that in my life. So I didn't make it a priority, which to this day I really regret. Because then at 50, she made me go in for a stress test, and I went in right before I was supposed to go to Germany for 3 weeks and leave the country for the first time in my life, and I was really excited about it. But I did not get to go to Germany. I got to go and get a quadruple bypass instead. So, so after the surgery, my cardiologist sent me to Dr. Moriarty, and he's the first one that introduced me to the FH Foundation and the fact that I had high lipoprotein A, and explained that my family history is the result of this genetic disorder. So I have now been a patient of Dr. Moriarty's for 8 years, and I called down today and I found out that I have had 146 treatments in 8 years, which is every 2 weeks. And the first thing I had to do was get a fistula, because they took one of my veins out of my arm for my bypass. So that really wasn't an option to do the 2 veins. So I ended up with a fistula. And well, let's see, where was I? I'm sorry, I got sidetracked. But which a fistula is just basically has turned into a novelty for my grandchildren, because, you know, not everybody's grandma's arms throb when they touch it. So they play with it a lot. They think it's really cool to touch it. So, but some of the results from apheresis is that my first treatment, my LDL was 297 and my LPLA was 106. And after the 3-hour treatment, my LDL dropped to 71 and my LPLA dropped to 29. So these numbers repeat every 2 weeks at about the same levels. And then, but I know the reduction is impressive, but the real reason I continue to do apheresis is its impact on my quality of life. On my way home from a treatment, I usually try and go straight home. Not a good day. I have a lot of brain fog, and I've been known to leave my car's keys in many places, and I'm always constantly going back into stores to find my car keys. So that is not a good thing. So I usually just try and come straight home. But by noon the next day, I feel great. I feel energetic. I'm focused and ready to get on with my life. And in last, during COVID, they canceled one of my treatments, and I really felt like I really hadn't realized how much I needed it. So by the 3rd week, my fatigue and not wanting to do anything and not wanting to get on with my life really set in. And I'm like, what is wrong with me? And I thought, I don't know what is wrong with me. And I'm like, well, I haven't had my treatment. So it really came back that I really needed to stay doing my treatments because it really affected my life after 3 weeks. So, so that's kind of what my story is about apheresis. The other thing I really wanted to share with you is that I have 2 homes. One's in Atlanta, one's in Missouri. They have apheresis down in Atlanta, which I'm very fortunate with, and in Missouri. Both of them are about an hour drive away. So I don't get a break on the drive. And I do get a break on the traffic in Kansas City versus Atlanta. But other than that, I still have to drive to it. But an hour is not, there's people that drive several hours, and I know that. But, I think there's a lot of advantages to having apheresis, but I still would take the medication if I could. Does that make sense?
That does make sense. I mean, I think what you highlight, Dawn, it's so helpful is that it's an important option for you. The other treatment options did not work for you, and that you found a way to fit it into your life. But I certainly wouldn't want to downplay the challenges, the time, and how you have to make a place for it in your life. But I think one of the things I thought was really interesting to hear from you is that you have made it fit into your life, and it's the treatment option that works for you.
We've only had one day I was driving, I try it. I am very careful with scheduling because I'm doing it in 2 places. And so I have to know my schedule and so I can pass it on to everybody else. And I got to KU one day in Kansas City, and I got a phone call from Atlanta. Are you coming in today?
Oops.
I felt horrible. I know I didn't schedule both places. I know I didn't. And, but it's a lot of money to start that machine up. So I am very careful and considerate to everybody. And so next time I went back to Atlanta, I said, what happened that day? I felt so bad. And they go, oh, that's okay. Somebody else was coming in and we just used it on them. So it made me feel a lot better. So
one of the questions that comes up is, I think for Dr. Moriarty, a lot of your patients who are doing apheresis, are they also taking other medications? Is it okay to take other medications while you're on apheresis?
Yes, it's definitely okay. And I wouldn't put anyone on apheresis till they've tried the medications that they need to try that would lower their LDL particularly. And then I use PCSK9s for LPLA for some of my patients if I can get them on it. So yes, they can take it, but when it doesn't work or it doesn't get them the goal, then that's when they have to come on to apheresis.
Thank you. And then I think one of the topics that Dawn touched on that I think is really important, we hear it a lot at the FH Foundation when people are considering apheresis. You touched on it, Dr. Moriarty, but the ways to access your veins, because it's removing the blood from your body, filtering it, and then putting the blood back in. My understanding is that there are 3 ways to access your veins. Could you briefly describe those 3 ways?
Well, the first wave is the normal ways, an antecubital IV, like you get an IV when you're getting IV fluids or something. And we use an 18 to 16 gauge needle. And if you have decent veins, and my nurses are pretty good at finding decent veins, you can get away with it. And as I brought up too, the blood flow was so slow, it's not putting a lot of stress on the arterial wall, the vessel walls that we're drawing the blood from. So it's like dialysis does, because dialysis at 500 cc's is really sucking that blood out at a high rate, and it could cause collapse. Where it doesn't have that. And if these patients don't have access, we're treating a 5-year-old girl who had LDL of over 900, and of course with her young age, she had to get the fistula to be put into her. And then the third way, and it's becoming more common now, is the ports. I tried ports 10 years ago and with not really good success, but the newer ports that are being developed seem to be working fairly well, where you put them underneath the skin, usually on the chest, and you really can't see them. And there are little bumps there, but you just put your needle in there, and it's very good access to use. So those are, I like them better than the fistulas now that the ports technology has gotten better.
Thank you. And I think, from the FH Foundation, what I would recommend to people is that if you're considering apheresis, reach out to us. We'll connect you with physicians and with patients and with nurses, importantly, who can help you understand those options so that you don't jump right in to getting a fistula or getting a port before you understand what your options are and getting the right port. I just think that's so important, because I think that because there are places where it's not, where you might be the only patient, you might be the first person that site has ever done apheresis, and we can absolutely connect you and your care team to others in the country who have experience so that you can start ahead.
Bring it up, Kat. Dialysis centers, all dialysis patients use fistulas ports. So these nurses, even though they're very talented, they're not used to doing vein to vein. So actually, they kind of like to go to a port or fistula because that's what they're trained on. They're not trained on going vein to vein with dialysis because it won't work on dialysis.
Mm-hmm. I think that's so important. And I think also you make an important distinction, that because I hear apheresis sometimes described as a dialysis-like procedure, but really there are some very fundamental differences, and it doesn't have those same considerations.
And the same thing with plasma exchange. It's not the same.
So that's important to know. And Dawn, I wanted to ask you, we had a question here that I think it would be really great to hear from you about, like, your tips and tricks for people who might be doing it, like, when do you hydrate? When do you rest? And some people, do you take anything before or after? And somebody's asking, what do you mean by brain fog? What will they be able to do? I'm sure it varies from person to person, but what's your experience?
Well, they suggested when I first started, and I still continue this today, is that you eat light the day before, like not a heavy meal, and then drink a lot of water. Be definitely hydrated the day before. I drink a lot of water the day before, and then the day of, you got to sit for 3 hours without going to the bathroom. So I don't drink. I drink a big glass when I first wake up in the morning, and then I just don't drink it till I'm done with the treatment. And I always have a bottle of water in the car when I get back out to my car. Now at Emory, they give you a can of pop, but but anyway, so everybody's different, but but the other thing is, that's the day before, and the day of, you cut back on your drinking so you don't have to go to the bathroom during your treatment. And then usually you get cold, and they usually have blankets or warm blankets depending on where you're at. And then and it's very, very important to tell the doctor or the nurses how you're feeling. If you start feeling nauseous, if you start having pain in your arm, if something doesn't feel right, you should tell them. Don't try and think, oh, I can get through this, because that's not what you're there for. They're there to help you, and they don't know unless you tell them. And sometimes you just think you should suck it up and not say anything, but that's the wrong thing to do. So definitely tell them if you're not feeling well, or if the needle hurts, or you're feeling pain. Oh, and then I always look like really good because I put that lanacine on my arm, and then you wrap it in saran wrap so it doesn't get on your clothes. And then your arm is definitely numb when you get there, so that you don't feel the needles going in. And I think Tom and I have dubbed our needles, instead of calling them needles, we call them our knitting needles, because they are big needles. So so we just laugh. And I never really realized how big those needles were until my son gave a horse an IV, and they're smaller needles than what they use on ours. So on our arms. So I was like, okay, I didn't really realize that. And the other thing is, they tell you to call 911 if you start bleeding. And I didn't really realize what that meant. until, you know, when they were trying to stop the bleeding, and sometimes the blood will shoot across the room. and this being graphic there for a second, but I came home and told my kids, if I ever tell you to call 911, do it. You know, I've never had any instances where I've had to call 911, but my nurses told me that every once in a while they do. And I've only had one time where I had to turn around and follow my blood drops back to the apheresis thing because my arm started bleeding again. And it wasn't that bad, but I didn't really notice it because I had sleeves on. And yeah, it was like, oh, well, somebody will clean it up. I'm not gonna worry about it.
Well, it's certainly, so it is, you know, it's certainly a serious procedure, not to be taken lightly. And I think that's really great advice for people. And I know we're close to time, and I have a few concluding slides because I want people to know about the resources that they can tap into at the FH Foundation. So as we said, it can be hard to find an apheresis center, but we have a list of centers in the United States and Canada on our website at the fhfoundation.org. We also have an interactive specialist map where you can find specialists, physicians, registered dietitians, genetic counselors, nurse practitioners who specialize in both FH and lipoprotein A, and more information about all treatment options all on our website at the FH Foundation. And the next slide. We have more webinars like this about cholesterol, about lipoprotein A, about diet, and much more about treatment options. You can find that on our website and also on our YouTube channel. Next slide. Lots of other educational materials, brochures, and you know, one of the issues that we haven't touched on today is that insurance coverage for apheresis can be challenging, but there is a lot of support to help get that through. And particularly at places like Dr. Moriarty's apheresis center at KU, they have a great team to help navigate that, but sometimes you need to be your own advocate, and we have tools to help you understand how to do that for any kind of treatment option and other educational tools. And if you find this and our resources helpful, we really are grateful for all the support that so many of you offer for the FH Foundation. And you can always make a donation at the fhfoundation.org/donate. And I just really want to say a huge thank you to Dr. Moriarty and to Dawn for sharing so much great knowledge and information with us today, and invite everybody who's attended to let us know. We'll have follow-up webinars on this and other topics, and we'd love to hear from you about what's helpful to know. And just thanks so much. It's really been great.
Thank you, Kate. Thank the FH Foundation for putting this on.
Thank you.